Saskia.
Okay. And that was Fur Elise by Beethoven. We're going to be coming back to that. We're already on live on Facebook and welcoming Dr. George Mikellides. Thank you so much for being in the studio here with me today. Very interesting subject in my research and preparation for our interview today, transcranial magnetic therapy. First of all, maybe we'd like to clarify, is that the same as transcranial magnetic stimulation?
Thank you for inviting me, Saskia, to the studio. I would like to clarify as well the question I've just started, that when we're referring to transcranial magnetic stimulation, we're stimulating the brain in different regions. When we talk about therapy in general, it does cover as well the inhibition of different areas of the brain. So we might either stimulate or inhibit the brain according to different protocols for different symptoms and different disorders. Just to clarify as well that in our days, we're discussing repetitive transcranial magnetic stimulation, which means thousands of pulses given within a treatment protocol. So we're talking about a lot of magnetic pulses within 3 minutes, within 10 minutes, depending on the protocol.
Okay, let's take it back a step and actually define what it is.
So basically, repetitive transcranial magnetic stimulation is a non-invasive treatment option for depression and other neuropsychiatric disorders. It has been approved by the Food and Drug Administration of the United States in 2008, and it has also gained a license in Europe, and it is within the NICE guidelines of the United Kingdom since 2015 for the treatment of resistant depression. So we're stimulating the brain. By stimulation, we produce dopamine, which is a neurotransmitter in the brain. The synapses, the way the neurons connect in the brain, changes, and we increase the activity of that area being stimulated.
How different is that from ECT, electroconvulsive therapy?
So it's very different in the sense that ECT produces a seizure, basically. It's like resetting the brain with a seizure being induced by electricity. And there are few differences are, for example, in ECT, the patient requires a general anesthesia, like put to sleep, like he's going to be operated, for example.
Yes.
So there's always the risk of general anesthesia in general, which is around 1 in 50,000.
Yes.
Also, there has been a debate in the scientific community if in ECT we get memory problems after having ECT done. ECT is got license for severe depression, psychotic symptoms, for mania, for catatonic schizophrenia, for example, where magnetic stimulation has a different way of acting in the brain, is by stimulating the brain. The patient does not require general anesthesia, can sit on the chair for 10 minutes, and then they can go on to drive, they can go home, they can go to work. So it's much more convenient, I would say, having rTMS than ECT.
If we go to ECT, are you actually put under anesthetic because of pain issues?
So you're actually put under anesthetic for different reasons. They have to give you muscle relaxants for your muscles to relax, because if you don't receive muscle relaxants, there's always a risk of a fracture. Just to remind our audience that back in the 50s, when they were giving ECT without general anesthesia, without muscle relaxants, they were breaking their jaws, breaking their hips because of the seizures, basically.
Yes.
So it's a way
it was horrendous. I mean, it looks absolutely horrendous.
We all remember the
Very
Jack Nicholson's movie.
Oh, yes. Barbaric.
things are very different today.
Yes.
ECT is a very good treatment option for severe depression when medications did not work. There's nothing barbaric about ECT these days.
No,
It's
but it
just-
seems that what you're offering is something
It's an
far
alternative.
less invasive.
Exactly. By the exact statement you have said, ECT is considered to be an invasive treatment, where rTMS is considered to be a non-invasive treatment.
All right. We have, of course, a lot of stigma attached to mental issues, mental illnesses, especially in Cyprus. How would you diagnose somebody who would need this kind of treatment?
So if the question is about rTMS,
Yes, generally, how do you actually get from the stage of the person being depressed? As I understand, it's primarily for treatment of depression. Maybe we need to go back a step and say, when is one depressed? What is the difference between depression and the blues?
all right. So
And then let's go on to I want to try and establish when somebody would be a good recipient for this kind of treatment.
that's very good. So I think it's important to clarify that our mood changes. We're not all the time happy. We might
Yes.
feel low at some point in our lives for a few days, for a few hours, because of something actually happening to us.
Yes.
So defining the criteria of depression, we are concerned about the time. So you have to have symptoms of depression for at least 2 weeks. So what are the symptoms of depression?
Yes.
Anhedonia, like not getting any satisfaction from your day-to-day activities, for example, like losing the sense of pleasure in a way. That's what we call anhedonia.
Yes.
Then there are changes in our biological symptoms, such as increase or decrease of sleep, increase or decrease of appetite. So that's another symptom. Those are symptoms of depression as well. Then basically we might spend a lot of time at home, not looking after ourselves, neglecting ourselves. Our concentration becomes very poor, so we cannot concentrate. Even like reading newspapers perhaps could be very difficult task to accomplish.
Yes.
Also to mention that energy levels are changing, so we might feel very tiredness a lot of the time, low mood.
How many symptoms would you need of what you just described in order to say, okay, this is depression?
So basically what we consider is not just the number of symptoms, which is also by criteria, it's important, of course, but we assess this patient as a whole and how functional is the patient in his day-to-day life.
Yes.
So functionality, it's an important factor to be considered. There are different stages of depression. We categorize them, perhaps mild, moderate, severe depression. We might think about 3 symptoms might be mild, and then 5 or more will be considered like a major depression, and 7 or more symptoms might be even considered severe. But
Yes.
at the end of the day, it's not just the number of symptoms, but assessing the patient you've got in front of you and taking the whole understanding of someone's day-to-day life.
How frequently would somebody actually say, I really need to go and see a psychiatrist? Or does one generally go to the GP first, and then the GP says, well, I do believe that you should go and see, for example, Dr. Mikellides?
All right. So it's very important to mention as well that depression is being treated in the primary care, like the GP, for example, a lot of the time with a simple antidepressant like an SSRI, like citalopram or sertraline, etc. And a lot of the time these patients don't reach the psychiatrist because they improve by prescription by the GP in primary care. Then when things become tough and things don't improve, that is when the GP will refer the patient to the psychiatrist. It's always better to get the specialist to assess you and decide for the appropriate treatment always, but it's always as well the cost-benefit criteria of different systems. Like when we talk about the NHS in the UK, people will receive an antidepressant first line by their GP. If things don't work out, then you get referred to your psychiatrist. So in Cyprus, we don't have a national health system.
No.
So people can go and choose to see a psychiatrist privately at any time they want, or even in the public health sector as well. They might choose to go and see a psychiatrist when they don't feel too good.
Do you find that that actually happens?
It does happen. It does happen for like anxiety, depression. People do actually ask for help. What happens is when we talk about patients with psychotic illnesses,
Yes.
like schizophrenia, for example, in the first episode, 99% of these people will not think they have a problem. They will genuinely feel that psychosis is a true thing in their lives. So those people won't reach for help. And usually what happens, their family will reach for help, or if they do something dangerous, perhaps the police or a social worker will try to get help
Yes.
for them.
You've preempted my next question, which is actually, how does one diagnose and see that somebody in your immediate family, because obviously it's the immediate family usually who sees a difference in somebody's behavior, whether they actually need psychiatric help. And parallel to that, where is the difference between the psychiatrist being needed as opposed to the psychologist?
Oh, that's a tough one there as well, but we'll try
Yes.
to answer both questions. I think what happens when someone suffers from a mental disorder in general, their behavior changes. So the people that actually live with this person, family, relatives, wives, husbands, they will start to notice changes, like in their habits, for example. They might not wake up to go to work. They might not eat as much as they were eating before. They might start to become much more having like temper tantrums, changes as such as like their libido, their interest in sex might changes. So there are a lot of different things that people who actually live with these people will notice the differences. The person itself will also notice the difference because they will feel like, I don't want to have sex anymore. So what's going on? I cannot have, I don't like the food anymore. I don't really like eating anymore. I can't sleep at night. But what's going on with me? Why I just get 2 hours of sleep when I used to sleep for 8? So people will notice differences as such. Then thinking about psychologists or psychiatrists, it's good to differentiate as well that there are different branches of psychology, like clinical psychology, where they have more experience with working with patients clinically, rather than like educational psychologists who might be working with kids in a school, for example. Psychiatrist is a medical doctor, and psychiatry, it's a medical specialty. So the psychiatrist will have an understanding of the person's whole biological background, taking into consideration their mental state, being able to put a diagnosis accordingly. Because, for example, if someone has depression and they reach the psychologist in the first instance and they consider that, okay, I don't want to go to psychiatrist because I don't want medications, which is not true. Going to psychiatrist does not kind of like guarantee you that you will start medications straight away, depending on your symptoms and on your diagnosis. So the good thing about going to a psychiatrist is taking into consideration your biological body. For example, if someone's suffering from hypothyroidism, like not producing enough thyroxine in the body, that's one of the causes of depression. So even going for therapy, like in psychotherapy with a psychologist, if you actually have blood examinations to test that there is something wrong with my thyroxine, you're not going to solve the problem. So my recommendation is it's good to work hand in hand, the psychologist with the psychiatrist, vice versa, and refer patients to each other for a more whole, complete assessment of the patient.
What happens if there's somebody in the family and they're in denial?
In terms of what kind of diagnosis do you have in mind?
You see that somebody is not behaving rationally, they're shouting, they're complaining, they're threatening suicide. You see incredible mood swings.
Yeah, just you're describing someone perhaps with an emotional unstable personality disorder, when mood swings and temper tantrums is a usual thing to see. And a lot of these people will not go to psychiatrists or to psychologists, and they might carry on threatening that they will kill themselves, and they will start self-harming and
Yes.
and putting themselves at risk. They're very impulsive, etc. And that's actually a hard and a difficult problem for everyone, not just for the family, not for just for the person, but for the psychiatrist as well. Obviously, take into considerations the Cyprus law. The nearest relative has the right to ask the court to produce a court order for someone to be examined by the on-call psychiatrist or the government psychiatrist of the day, just to verify if this person is dangerous. They might be dangerous, they might be at risk of killing themselves, so we need to assess that. But people with personality disorders, they have long-term risks, for example. They might say, I've got fleeting suicidal thoughts, I'm in my 30s, I've been thinking about that the last 15 years, I have tried to kill myself 10 times. Is what do you do with these people?
Yes.
Which is very, very, very difficult, actually. The way forward is psychotherapy for them. But in this case, in this kind of diagnosis, we see that at least 50% of them will drop out therapy.
So that's a very high percentage. And how do you ensure that they stay there?
You try. You try to convince them that therapy is important for them. You try to challenge them, because going through therapy, it's very challenging for everyone.
Is this because the therapy, they don't see results immediately?
That's another actual
You
fact.
want to feel better immediately. I mean, something very banal. All right, just to change the seriousness of the subject. You say that I'm going on a diet. Well, if you haven't lost 2 kilos by tomorrow, you say, well, never mind this. Is it the same?
Yeah, and we should not forget that going into therapy will bring traumatic experiences of the past. People with personality disorders, they might have experienced like traumas such as sexual abuse, physical abuse, emotional abuse. Going through therapy, this will come into the light of the therapy. So what's important is you have to try and be strong in a way and to walk through this path with your therapist, which is not an easy path. That's why people will drop out. That's why they will leave therapy and they go and get drunk, because it's a way of coping for them, which is maladaptive, obviously, but that's how things work.
I was horrified to see a very high drug issue and drug problems. How does one actually realize that somebody in the immediate family is on drugs? Because you've said that you need to get evaluated. You need to get a court order in order to get the family evaluated. So that must be a horrendous step in order to go to Athalassa Psychiatric Hospital. We've heard the most horrendous reports about what goes on in there. So how do we know, is it drugs? Is that something that can be stopped? Do you still need to be evaluated and taken to Athalassa in order for this to happen?
I mean, there are people that they use drugs and they don't have, let's say, a mental disorder. They are sporadically using drugs, like people going out on a Friday and they use cocaine, for example, like drinking alcohol. Obviously, they have an issue there that needs to get help. But not necessarily having a mental disorder.
Is that possible, to do cocaine only on the weekends and not to be addicted?
Yeah, exactly. So there are people that actually, like for example, when I was working in London, I could see like lawyers, doctors using drugs, like going on weekend out and Friday night and Saturday night and going back on Monday to work. Like nothing like happened on Friday or Saturday. So when we talk about addiction,
yes,
then we talk about a mental disorder, when someone has an addiction to drugs. So obviously, if you have an addiction, that means you're daily using drugs. But then again, having a mental disorder due to the use of substances does not require you to be admitted to a mental health hospital, unless you lose your capacity to decide for certain things, or you're basically an immediate risk to yourself or to others, or you're psychotic, meaning that you break reality, you believe in things that are not true. You might feel, for example, that the KGB is after you, or the CIA is behind different conspiracy theories, and you are the target. So you might experience brief psychotic symptoms under the influence of, for example, methamphetamines, which might wear out within hours or within days, depending on each case, basically. So, yeah, it's a huge issue, actually, the drugs in Cyprus. And I was reading the other day a newspaper which commented that Limassol made it to the top 10 of crystal methamphetamine use in Europe. So we're doing good, in not actually in a good way of doing good.
Absolutely horrendous statistics. What, in your opinion, can and should be done in order to get off our list?
I think that there are a lot of governmental and private clinics that people can reach for help. The issue there is that a lot of the time drug users, they don't want to get help. They just say, I like doing drugs, doctor. I'm not going to stop using drugs. You cannot do anything for these people. If you're a smoker and you smoke, and the doctor tells you, your GP tells you to quit smoking, gives you the advices, shows you the facts of your heart, diabetes, etc., they cannot take a gun and point it at you and tell you, if you don't quit smoking, I'm going to shoot you. So you cannot do anything, really. And that is the difficulty we're facing in Cyprus and in other countries, that the families might want their children to quit using drugs, that their children don't want to quit.
So there's nothing actually that can be done short of admitting them into a psychiatric unit.
Yeah, but that can happen actually for a brief amount of time if the criteria are met, like the ones I described earlier.
Yes.
Like having psychosis, like believing in things that which are not true. You're at an immediate risk to yourself or to others. So those are the factors. You might smoke skunk here, and you might be the happier person in the world.
Yes.
No one is going to admit you to mental hospital if you're not posing risk to anyone.
So if somebody is in this position, I would think that the family would be beside themselves and really need help and support. And depression must be part of that family's surroundings. Let me just say parents, for the sake of argument's sake, who have a child who's doing drugs. What does one actually do? Do you distance yourself? Do you practice tough love?
That's a very tough question, and there is no wrong and there is no right. What's important in someone's life in general is to set boundaries. Boundaries should be there, like from family to their children. Or, they can say, my son is asking me for 50 euros to go and buy his toes. If I don't give this money, he's going to be unhappy. He's going to start threatening me to kill me. What can I do? I just give the 50 euros. But that's not the way forward. You're actually perpetuating a situation that never ends.
Yes.
So a lot of the time we have advised families, even changing houses or getting a restriction order against their own children, because it becomes very, very risky for them sometimes.
Is this if they're over 18? What about if they're under 18?
If they're under 18, so obviously it's the family and the social services should be involved as well, because the family might not be capable of managing the whole situation, and everything needs to happen through the court system, I suppose, which is not easy.
No, it all boils down to a recurring idée fixe that we seem to have in Cyprus, and that's a lack of enforcement. Because if things are enforced, so you say, for example, if the 50 euros isn't given, and that rule is enforced, you're not collecting money from me, the rules of no smoking in public places is enforced, our society in general will work in a whole lot better way, won't it?
Yeah, it does make sense, actually.
And then maybe we won't have so many depressed people. Because I think that we must have a quite high percentage of depression in Cyprus. Did you, you were here in 2013?
Actually, I came back from UK in 2015, but I do understand the difficulties.
The crisis. How did you realize that there were more people who actually needed your help? Maybe they actually landed up coming to you in 2015.
Yeah, of course. Any changes, any financial changes, any social changes in someone's life can trigger anxiety disorders, depression, suicidal behaviors, suicidal attempts. So those are stresses that can actually affect your mental state, and they can potentially increase the rates of depression and anxiety disorders and breakdown in general, let's say. But we see depression even in rich countries, westernized countries. And what we can say today, what actually plays a huge role in our day-to-day life is the social comparison. We tend to compare ourselves with everyone else. Who has a better house, who has a better car, who has a better job. So if I'm not meeting my expectations, then I might not feel happy. Even though I've got a decent salary, I've got a decent job, a decent house to live, and those are factors influencing us, really.
Social media has a good role, but it's also got a bad role in what you've just said to play. That sort of idealized image that one has to portray, that everything is fine. You can't say, you know, you're angry, you're fed up.
So I think
that isn't really acceptable, is it?
And they actually present a different kind of life, which is not real. People might be smiling on a selfie on Facebook and pretending to be in the happiest place in the world with their couples. And at the end of the day, they might be very unhappy. And I mean, there's some research thinking about selfies and stuff and trying to present yourself as happy when you're not. And getting approval from people, being approved by your family, being approved by your peers, and presenting something which is so fake and can actually make other people unhappy, because the social comparison hits again and tells you, oh, look at this person, he's like in Seychelles and having a great time, and I'm at work from 9 to 9 doing nothing. I wish I was in Seychelles with this person, let's say. So that's a reality we're facing today with the social media and posting of pictures.
It takes courage. I think it was Einstein who said that, to move in the opposite direction and to actually and I think it's not only courage, I think it's also age. The older one gets, the less one worries about these social appearances. I think if I'm not mistaken, it's also directed in certain groups and ethnicities. Some are very much more aware of themselves and the pictures that they portray. Have you found that to be true?
I think it is true, and we can see that like in Cyprus or in Asian communities in the UK, when they have high expectations for their children to become doctors and lawyers, even sometimes their own children don't want to do that. And when you're pushed into studying something which is not relevant to what you like, you might become depressed later in life because you're doing something day to day, day in, day out, basically, without being happy. And you have done that because those were the expectations of your parents. And I think certain communities, small communities, there is a lot of high pressure on you to be successful, to be better than the neighbor, to be better than someone else. And this is an extra pressure that people get in Cyprus because the comparison to the people next door, it's day-to-day reality, basically.
Do you find in your practice that you have a lot of teenagers who are showing signs of being depressed?
Usually work with the age of 17 and above, so
Yes.
I don't tend to see under the age of 17. But when they actually reach to us when they're 17 or 18, we can see in their history that they were depressed since they were like 12 or since they were 15. So depression can hit any age really, and it's not like a disorder of the adults or a disorder of the elderly.
No.
Depression can hit any age. That's anxiety as well. That's
Yes.
OCD as well. That's schizophrenia. That's bipolar. You can get bipolar when you're 15.
This was actually a question that we had from Facebook that I wanted to ask you from, and it was from a person called Sandra, and she said, how do you differentiate bipolar disorder from mood swings?
Okay, mood swings is actually a symptom. So it can be a symptom of emotional unstable or borderline personality disorder. Mood swing basically refers to changes of your mood perhaps within a day. So few hours of happiness, few hours of being sad and depressed, and perhaps thinking about killing yourself. When we think about bipolar disorder, those episodes need to stay longer. So in bipolar disorder, when we think about someone being happier than usual, a term we have of hypomania, or extremely happy, being mania, being
Yes.
manic,
Yes.
then this needs to last for days. So some people, there's a debate about what's the amount of days of hypomania or
Yes.
mania. And when we think about hypomania, we think at least of 2 days and more of being happy or over the edge of happiness, basically.
Yes. Yes.
And mania, we're thinking about a week of extreme happiness, which can be accompanied of different presentations. Sometimes people with mania, they can experience psychotic symptoms as well. They can start to think, I am God. I'm the creator of the universe. So what shall I do today? Shall I just fly to States? And then you jump from the 4th floor and you kill yourself because you thought that you're, let's say, God, and nothing was going to happen to you if you flew from the window.
Right.
So mania, it's very dangerous. Mania should be treated in hospital most of the time. So mood swings is something completely
Yes.
different, really.
We've also had another personal message which came from a mother who's experienced a gender transformation. The child is over 18 and is very lethargic, doesn't want to do anything, and is actually threatening. They're on drugs, on cocaine, and threatening the mother.
So did you also mention there is a gender identity
Yes.
disorder
Yes,
and a drug
a
use?
transgender child,
So
moving from male to female.
and have they done the change or not yet?
She hasn't said.
She hasn't said. Because it can be extremely painful and difficult for someone wanting to change their gender and not going through the process. For example, not receiving hormonal support.
No, they've received that, and
They
I mean,
did.
yes, physically, and they've identified. They've changed.
And they have done also the
I don't know
surgery.
if they've done the surgery.
Okay.
That's she wasn't clear about. It wasn't a private message.
I think the difficulties we're facing here is acceptance. Acceptance in a community such as Cyprus, which we can see sometimes the religion and Christianity, the hierarchy of the Greek church, the Cypriot church, that they don't consider this as physiological or as normal lifestyle and behavior. And we need to clarify that transgender is not choice, right? It's the same as being straight or gay or bi. This is who you are as an identity. So trying to suppress those feelings and those thoughts can always lead to depression, anxiety, suicide, and this has to be taken into consideration by professionals such as doctors, surgeons, and endocrinologists, which they support the hormonal support. Sometimes because of the difficulties these people are facing, even in employment, even in acceptance by their parents, by their siblings, by their friends. They might turn to drugs to try and numb those kind of difficulties. Because if you feel depressed and you do cocaine, you might be happy for a few hours.
Yes.
And then you go back to your depression, you're miserable, you go back to cocaine. So what you need to do is to take treatment, basically, for your depression. And you should be allowed to do what you want to do for yourself. If you're not allowed to go through the process of an identity or a gender change, you might end up killing yourself. So these people that in the media, that they say, oh, this is a sin and this and that, they should consider that these people are under a great risk of killing themselves, and they should allow them to do how they feel like about themselves.
Okay. Going back to your transcranial magnetic therapy,
Right.
is this something which is new in Cyprus?
Yeah.
Are you a founder?
Founder psychiatrist of
Found-
rTMS in Cyprus.
Yes.
As far as I know, I am the only psychiatrist who does this at this moment in time in Cyprus. That is why I was given a license through the ministry to apply the rTMS, because I'm working in the hospital as well,
Yes.
as a locum psychiatrist, basically. So to clarify that rTMS, it is an innovative therapy.
Yes.
It is a new therapy. The evidence in literature is growing for different things. We can see that can help people with migraines, people with fibromyalgia, with tinnitus, disorders that usually a lot of the time physicians might say to the patients, like I heard patients having tinnitus, but they have been told, oh, you're going to live and die with it. So there is
Just
no
for
treatment.
people to know that's a ringing in the ears,
Yeah,
continual
exactly.
ringing in the
Yeah,
ears.
that's just irritating noise,
Yes.
basically.
Yes.
There are articles, there is research being done, for example, for rTMS, and some research suggests that 50% of people receiving rTMS might improve in their symptoms when they have a diagnosis of ringing
Yes.
in their ears. We can see people with migraines even reaching 70 to 80% improvement. Depression can be up to 70% of people improving. And negative symptoms of schizophrenia has shown in literature that can help as well. What is negative symptoms of schizophrenia? Is symptoms which the patient presents with apathy, like there is like no facial expressions, there is a lack of enjoyment, lack of desire, isolating themselves at home, not working, not doing much for themselves, anhedonia, lack of pleasure again. So it has been shown in literature, in the same way we stimulate the brain for depression, we can stimulate it in people with schizophrenia. And there's some evidence as well in auditory hallucinations, people experiencing with schizophrenia, that can be helpful, the rTMS.
Yes.
Also in epilepsy, there are studies like it can help people. So, I mean, generally speaking, what we need to consider when we consider rTMS, because it can be an expensive option.
Yes.
And because I remember you have
expensive
started...
for each session, or that you need it over a prolonged period of time?
It's basically, if we're talking about depression, you need 20 to 30 sessions.
All right.
Which is 5 times a week. So the patient needs to come to your clinic 5 times a week, or sometimes you can maybe perhaps do 4 sessions and a double session to make up for the one that the patient was not able to meet.
Right.
So it can be sometimes the convenient factor might play a role, but remember that a lot of the time people with depression are not actually working.
Yes.
So getting to the clinic is not a huge problem, because they won't be skipping work and they will be receiving treatment.
And how long is each treatment?
So that's a good question as well. So the FDA protocol for depression is 37.5 minutes.
Oh, I'm glad you told me the 0.5.
Yeah, but listen to the good part now.
Yes.
There is so-called theta burst stimulation, right? Which is a pulse within 200 milliseconds. Many pulses together.
Yes.
And it's as effective as the 37.5 minutes. 3 minutes on the chair, the same with 37 minutes. So you can choose to do the 3 minutes or the 37 minutes. It's the same results, basically. So if it was me, I would choose the 3 minutes, because I don't have to sit on the chair for 37.
Exactly.
But obviously, to bear in mind as well,
there's no difference.
There's no difference in the effect. I can show you the studies
Wow.
done on a huge number of patients comparing that.
Yes.
And also, what is important to bear in mind that there are centers that they do rTMS. I'm not talking about Cyprus. I'm talking
Yes,
about the
abroad,
Europe and
yes.
abroad. That they don't offer the theta burst stimulation because it's a more expensive equipment they need to have.
Right.
So they might do the classic TMS, which is not theta burst, which is not a
Okay,
3
so
minutes.
theta burst is actually the way to go.
It's the way to go.
On the
3
chair.
minutes on the
3
chair.
minutes on the chair. I mean, if I was really not feeling well and I had that option, I think that's one would do it. Is it covered by medical aid, insurance?
Okay, so I'll clarify as well that, because I think there was a question earlier, we didn't cover it completely. Who is it for?
Yes.
And I'll come back to the
Yes.
insurance. I mean, it's a choice. So a patient might not want to be on medications for depression. So they might want to choose to have rTMS because it's an effective treatment. So, when you get antidepressants, usually you get some side effects such as increase of weight, changes in sex drive, changes in sex in general. I'm not going to get into details at the moment
No.
about the sex problems that people might have being on antidepressants.
All right.
And like blurred vision. But usually what I hear the most about antidepressants is the sex and the weight. That is what I hear from everyone, women and men, complaining about medications
Yes.
in terms of antidepressants.
Yes.
So if you don't want to be on meds, you can do rTMS. That sounds like it's rhyming, right?
Yes, yes.
But that's let's say for depression, which is licensed treatment. You can also think like when medications are not sufficient. So someone is depressed, treatment resistant. Medications did not help the patient to recover. So that's a second option, for example, right?
Yes, yes.
And sometimes you can combine medications and rTMS as well. So that's
All
another
right. Or for
option.
people who really don't want to take medication.
Yeah.
So now
Or when medications are not sufficient, basically, they don't recover from medications. Or like the uncontrolled epilepsy, for example.
all right. And if it's going to all right, let's go.
Let's go back to the insurance.
Yes, before the insurance, have we got an age limit?
No, there is no
or
age.
minimum?
There is no age limit. There are
We've got
contracts.
children with epilepsy.
Yeah, I mean,
Are they suitable? Obviously, if you've seen them.
Obviously, I'm a psychiatrist, so I will closely liaise with a neurologist in the case of epilepsy that
Yes.
actually follows the child. Recently, a GP called me and said, George, I had a conversation with a neurologist from Israel
Yes.
about a kid who has an uncontrolled epilepsy. And when I was asking, what can we do in Cyprus? And the first thing the neurologist in Israel actually said, do you have rTMS in Cyprus? Because they have been using rTMS for epilepsy in Israel.
Yes.
So obviously,
With good results.
with good results,
All right.
you wouldn't use it if you don't
No.
have good results. So I think if there is a specific case, I would closely liaise with the neurologist, and we will come up with a plan in basically in both having the same kind of agreement and same path. What's important is there is no age limit, I think. And obviously, I'm not a child psychiatrist. I will repeat myself. I'm a general and liaison psychiatrist. If there is a child, I will closely liaise either with a neurologist or with a child psychiatrist to see what can we do in this case. We're actually considering now cases which are extremely rare in terms of like not being managed on medications, for example, on epilepsy, but we do have them sometimes. So we need to discuss it. We might have a case conference and discuss it in the sense, what are we going to do?
Conference has brought another thought to mind. How many doctors are actually aware of transcranial magnetic therapy?
Not many.
And shouldn't there be a conference in order to enlighten them that there is this positive research that's been done, that this is a non-invasive way of treating so many varieties of illnesses and symptoms.
So what happened last Saturday, there was the Pan-Cyprian conference done by psychiatrists in collaboration with the Institute of Neurology and Genetics and the Child Psychiatry Association as well. So I did present it in the group of people that they were present. I think there were around 50 people in the audience.
Oh dear.
But obviously, people need to know about it. People need to know. And I can say that there are different specialties, there are different doctors, that they don't know much about rTMS. It's such an innovative therapy.
Yes.
And
how long has it been around?
Where? In the world?
Yes.
So FDA...
Because, I mean, Cyprus is always sort of at the end.
So the last 10 years. The last 10 years.
10 years we should have known about it. We're supposed to be in Europe.
Obviously, I do know about it, and I've got
yes.
Cyprus.
I mean...
I know, you're right.
I mean more doctors.
And this is actually, I can show you, this is the guy behind rTMS.
If you move a little to the right.
Yeah, so it's
yes.
Dr. Anthony T. Barker, if I pronounce it right, who began exploring the use of magnetic fields altering the electrical signaling in the brain back in 1985. So he started more than 30 years ago experimenting on brain stimulation with magnetic pulses. And we're back now to 2018, having an FDA approval treatment for depression, and it can be helpful in other neuropsychiatric disorders as well.
Let's go through the actual steps so that people can be aware of it and more open. It's diagnosed. You decide that this is the correct therapy. What happens in the next step? I come to you, I sit on the chair.
So let's say you get diagnosed with depression.
Yes.
And is that your first episode of depression? You've never been depressed before?
Well, yes. Let's make it the first. Let's make it the second one.
Let's make it the second one.
The second one.
Are you on medications?
No, I don't like taking medications.
Okay. So depends of how depressed you are as well. Because if you're a bit depressed, if you're mildly depressed, there is an option, self-help books, there is an option.
I've passed that. I've already read all the books, and I think that I know everything, and
nothing has been helpful.
Nothing's really been helpful. So I'm in that stage.
So obviously there are three options. There is medications, there is psychotherapy, and there is the brain stimulation.
Yes. I've seen you, and you've decided that that's the best, and I'm going to be... I've agreed to that.
You agreed to that. So what we do, we can start next week, let's say.
Yes.
The sessions usually at this moment in time is Tuesday to Saturday every day.
Yes.
So you'll come to the clinic for 5 minutes, and then you go back to doing whatever you were doing.
All right.
Prior to being in the clinic.
Am I in pain? Do I get wired up, or what?
So what happens is basically the good thing about, I did say earlier about that there are no major side effects compared to medications. 5 to 20% of people might have a headache after the session. This usually happens because your brain works a lot.
Yes.
So it gets dehydrated.
Yes.
So you need to have a bottle of water just after the session. So you drink the whole of bottle of water.
Yes.
So you don't get a headache.
Right.
And usually people don't get a headache when they drink a lot of water after the session. Obviously, there are the rare ones. 1 in 10 might have a headache, and they're very sensitive. They can even take 2 paracetamols prior to the session to avoid a potential headache.
All right.
Sometimes people might feel a bit sensitive at the side of the application because it does stimulate the skin. It's like someone tapping on your head. So if someone is tapping on your head for 3 minutes, you might feel a bit sore sometimes, but nothing really major, just wears off really. So 20 to 40% might experience a bit of discomfort at the side of stimulation. Also, you might get some twitching of facial muscles at the time of the applications, because as your brain gets stimulated, the facial nerves will get a bit of stimulation. So you might have a bit of twitching at the time of the application, which is nothing to worry. Nothing is going to remain after we stop.
Just sorry to interrupt, but because you've said that, would it be helpful in TMJ?
Yeah, that's a good one.
I've just thought of that. You know, a lot of musicians suffer from that, especially violinists and viola players.
Yeah, actually some people were asking me about TMJ and what is in the literature. So you're referring to temporomandibular joint pain usually.
Yes.
So what happens is there are evidence to show that it can help the neuropathic pain or the pain in general, not just for the TMJ, but it can be helpful in pain management. So what happens, you stimulate the contralateral, meaning the opposite side where the pain is, the primary motor cortex, that's where our brain basically controls all movements.
Yes.
So you're asking a very specific question, which there might be something in the literature, but the evidence will be small. But generally speaking about neuropathic pain or pain, there is a lot of growing evidence that can be useful.
Right. Okay, so I'm sorry I interrupted you. So we're sitting on the chair. We've got tapping on the head. We're going to drink water. We're going to take 2 paracetamol. And then how many sessions will I need before I feel
start to see something?
Really, I don't feel bad today. I'm going to get up and, cut a flower from the garden.
Yeah. So usually people would describe a change after a month. So 4 weeks in treatment. Some people might say a bit earlier, within the end of 3rd week, let's say. But mostly people will improve after the 4th week.
Is this something then that has to be continued on a regular basis?
In terms when you complete the treatment or course?
You've done a course of 4 weeks, 5 times, 20 courses, 20 sessions.
Yeah. Obviously, if you have severe depression or if you have a history of several episodes of depression, I might recommend you not to do just 20. You might want to do 30. If it's your first episode and we both feel that you're not severely depressed, we might say maybe 20 is an option. Yeah, it depends on case by case if we say 20 or 30. There is some literature which basically suggests that people can go on maintenance or treatment.
Yes.
Especially with patients that they have a huge history of being depressed in the past, a lot of depressive episodes. So there are some advices which recommend maybe once a month maintenance treatment after you complete the course of treatment. So you might want to do 6 sessions of maintenance monthly, basically, after the course of treatment, just to make sure that you will basically sustain the treatment. But what people sometimes ask me is, okay, doc, I'm just going to do this treatment. Does that mean I will never get depressed again? The answer I give to them, if you break your leg and you fix it, will you never break your leg again? I mean, it's just, I think sometimes it's common sense in that sense.
It's a fascinating subject. What other, we've covered depression primarily. What other psychiatric issues and I don't know, diseases, I think isn't the correct word. Is that diseases? Do you feel people can be helped?
In terms of the transcranial?
Yeah.
So there are evidence in PTSD, for example, in the post-traumatic stress disorder.
Yes.
There is evidence in anxiety disorders. In addictions, there's some evidence as well. When we talk addictions, the evidence has shown in some randomized controlled trials that can be helpful in people, for example, smoking. So smoking...
you could actually help a smoker to stop.
There is some evidence, and I heard as well in Israel they use that for people to quit smoking. You can use it in collaboration with nicotine patches, and you can have 10 sessions, 5 a week. There is a study which compares 18 people in 2 groups receiving rTMS, nicotine patches, and the other one was sham, like fake rTMS and nicotine patches. From the 18 people in the group that received rTMS and nicotine, 16 managed to quit, so only 2 failed. And in the other group, from the 19 people, the fake rTMS, only 9 managed to quit, less than 50%. So there is evidence in RCTs for smoking, and there is some evidence in cocaine, for example, uses that can be helpful. And there are different studies are done around the world about perhaps aggression or improving symptoms of Parkinson's. Sometimes we can see the rigidity in Parkinson can be helped perhaps. Also, we did mention epilepsy. And there have been some small studies on autism that it can improve or decrease the restlessness that the people feel with autistic spectrum disorders, because it can calm down the brain, as we said. You can use either stimulation or inhibition of the brain. And there is a list of different things that perhaps we can think. People can find more information on my website
I was going to say, please, can you direct people to the website so that
so the website is drmikellides.com, drmikellides.com, and if they choose rTMS on top, they will find information either in Greek or in English explaining about what is rTMS, how does rTMS work. And they can also find us on Facebook. We have created a page and a group as well called Cyprus rTMS. So now we have named our center Cyprus rTMS. So for people, they can reach to us easier. The other day, I had a call from Jordan asking me how expensive is rTMS in Cyprus and if they could do rTMS coming from Jordan. So we can think that perhaps slowly but surely people will find out about rTMS, not just in Cyprus, but in our neighbor countries.
Thank you so much for giving us a substantial amount of your time. I think that this is clearly an option for many to consider. The fact that it's non-invasive, the fact that you're here in Cyprus, you're extremely knowledgeable, all a very big help. So people should actually just find you on the page, or are you able to give out
I can give my phone number out as well.
I didn't know if that's contravened. Okay.
It's on the internet, so they can reach my phone number is all over the internet. They can text me for questions if they have any, or they can text me on Messenger. My phone number is 99430-330. It's quite easy to remember, I think.
Yes.
Too many threes.
99430-330. And I have to say that Dr. George is one of the coolest psychiatrists that I've ever come across. Thank you so much.
Thank you for the greatest compliment.
I think that you've dispelled all those notions of,
I'm not too scary, I hope.
No, not at all. Very warm and very easy to speak to. Thank you so much.
Because sometimes, just sorry for interrupting you, just to make a bit of a joke, really. But people imagine psychiatrists like the people they will lock them in a mental hospital, lock them up in a mental hospital, and give them loads and loads of medications, which is not the case.
No, that's clearly the point, and the fact that you're always so open and friendly. Thank you very much for being here with me.
Thank you, Saskia.
And dear listeners,